Assalamu alaikum with Professor Dilip to open his session, and each speaker will have maximum 30 minutes, and I would kindly ask the speaker to stick with the time so that we be on time in concluding the workshops. Okay. Thank you.
Okay, thank you very much, Manaf. Good morning, everyone. This session is around setting the scene around resistance and prescribing in a global setting. Can I also emphasize what Dr. Al-Katani said, that the workshops are particularly important that you engage with the two people who will be facilitating the workshops. So share your experiences and your thoughts in relation to many of the topics that will be covered, because it's only by your interaction will we be able to make sure that you share, you learn, and you go away with some knowledge that hopefully you will share with colleagues in your own organization. Okay, so I'm just going to, I think it's this one here. And it's this here.
And you can use that point.
Okay, thank you very much. What I'd like to start off over the next 25 to 30 minutes is really give you a very broad landscape of the problem of prescribing across the globe and what my limited understanding of stewardship is, and what you'll get is really setting the scene for many of the plenary and workshop sessions for this morning as well as this afternoon. So again, it's a pleasure to collaborate with the Gulf states, but on this occasion, particularly Bahrain, and on behalf of my colleagues from the British Society of Antimicrobial Chemotherapy, we're delighted to be here. We have very good relationships with many of the speakers and faculty, and we hope to continue this collaboration in the future. The objectives today are around setting the landscape and then discuss what is this concept of stewardship, what are the core elements and the interventions, which you'll hear in more detail later this morning and in the workshops. I think if you saw the news yesterday, you see the news over the last 5 years, antibiotic resistance is in the news everywhere because of the problem of resistance, the impact of resistance, and particularly in many parts of the world, the increasing difficulty in treating multi-drug resistant pathogens. And there clearly is a need not only from the medical community, which is us, but from the political community, from patients and the public, a recognition that we need to do something about it, and we need to do something about it very quickly. And this is why I suspect many of you are here. And if you look at on this slide, the incidence of antimicrobial resistance is increasing and its impact is substantial. This is in the sense of the number of likely cases of drug resistance in the different continents, and the bubbles within the continent represent the likely mortality from these antimicrobial resistant pathogens. And then it's pictorially and visually very stunning that how many people are likely to die, not only now, but over the next 3 to 4 decades. And when you look at in terms of the impact, by the year 2050, it is impacted that there will be 10 million cases of multi-drug resistant pathogen infections, much higher than, for example, many cancers and many of the other diseases that we recognize as a huge impact on healthcare burden. And a recent report published in the United Kingdom told that the global cost of antimicrobial resistance is going to be projected by 2050 in the region of $100 trillion. So this really is why many of the politicians, as well as us as healthcare professionals, are increasingly interested in this area and recognize that we need to do something, because this is a huge public health threat for the people that we look after. So I know in the Gulf you enjoy Who Wants to Be a Millionaire? Okay, so I'm going to ask you to just write down your answers to these 5 questions. I'm not going to ask you to put your hands up, but I'm going to ask you before I start the lecture, and then you can see if you got these answers right when we get to the end of the lecture. Because The first one is that we have seen a global consumption in the decade between 2000 and 2010 of a 50% increase in antimicrobial or antibacterial consumption. So is that a correct or an incorrect answer? Put that down. The misuse of antimicrobials in the Gulf region and the Middle East is not common. So put your answer down for that. The stewardship goals are to improve patient safety, to improve outcomes, at the same time as attempting to reduce costs and stabilizing or reducing resistance. Those are the 4 aims of stewardship. So if you agree with those aims, put down true. That how we educate, these passive education methods, what I am doing to you now is the most effective way of educating and improving prescribing. If you agree with that, put true. If you don't, put false. And lastly, but not least, that leadership, getting somebody to be accountable for prescribing, having a clear goal, working as a team, and having data that will help you prescribe and improve your prescribing are key components of a stewardship program. If you agree with that, put true, and again, false. And I will reveal all at the end of this lecture. Okay, look where we've come. This is a patient presented in the proceedings of the Mayo Clinic in 1943, a young 4-year-old girl with a high fever, facial infection that is spreading, and this is what she looks like when she's admitted to hospital. And after 14 days of wonderful penicillin, this is what she looks like. And I'm sure all of us have become so used to using antibiotics and noticing the powerful impact these antibiotics have in the patients that we look after. And if you look at the intervention of antibacterials compared to many other medical technological interventions, it has had a dramatic impact on human health. And this slide from the United States is showing that the death rate from infections after the introduction of penicillin has been substantial and phenomenal. But now, where we are in many of the vulnerable societies of our world, this is data from India showing the large number of neonatal deaths from multi-drug resistant pathogens, and the world is not a small place. So we are facing a reality in many of the infections that are now occurring in many parts of the world are not easily or not at all treatable with the antibacterials that we have available to us. And we recognize that how we have destroyed the resource of water, increasingly oil, fishing, is we will abuse the resources that this planet has, and in a similar way, we do that with antibacterials, a very precious resource that we are in danger of destroying. So, I'll put a case scenario, and I'm going to ask you, is this familiar to you? A 45-year-old patient with acute myeloid leukemia, usual standard of care, chemotherapy, insertion of PICC line. During his chemotherapy, gets prophylactic drugs, becomes neutropenic, develops sepsis and fever, and the blood cultures reveal the growth of gram-negative bacilli. He becomes very unwell, and ultimately the cultures come back as a multi-drug resistant Pseudomonas infection. The lab gets in touch, and the organism is resistant to carbapenems, aminoglycosides, and even worse, colistin. Is this unusual to your setting? What are the consequences for this patient? And what antibiotic would you use now? Is the question that you've got to ask in your hospital if you looked after this patient. If you look at the status about is this unusual, this is data from across Asia for multi-drug resistant Pseudomonas. It shows that very high incidences across the Asian subcontinent, and the only data from this part of the world is from Saudi Arabia in the region of 10 to 25%. If you look at a more recent data, look at the prevalence of resistant Pseudomonas in Saudi Arabia, 92.3. It may not reflect all of Saudi Arabia, so this is the importance of understanding local epidemiology. But look at the resistant prevalence rates across the Gulf states for different pathogens. So you've got to begin to understand, is this a scenario that is relevant to your part of the world? What is the impact, was my second question, of these multi-drug resistant pathogens? First, the impact on the hospital and the patient. An increased risk of mortality. That matters to the patient and their carers. Second, the impact is on the hospital. It will increase the length of stay due to the episode of infection. The attributable length of stay is increased for all the different drug-resistant pathogens that I talk about, and it will cost more to look after that episode because you'll need more investigations, more time in hospital, and more antibiotics to be able to treat these episodes of infections. So the impact is quite considerable. If we are to deal with resistance, we need to have a holistic cross-system approach. We have to look at horticulture, agriculture, fisheries, at the same time prescribing in the hospital setting. But remember, the majority of prescribing occurs in the community, and this is what we don't talk about today because the focus of these 2 days are around hospital prescribing. And this has really, in a sense, brought up this concept of One Health, in which we look at the interactions between human prescribing and everything else that occurs in the environment. And increasingly, you'll read about One Health as how we tackle the global problem of antimicrobial resistance. And this is now protests in Berlin telling the German government that we need to think about how we use antibiotics in livestock. So the message here is that today what we're doing is a very small component of how to deal with the global challenge of antimicrobial resistance. And when you look at the prescribing, this is very old data, but it's still very valid, that if you look at human prescribing, 80% or more is prescribed outside the hospitals, and only around 20% in the hospital setting. And up to half of that is either unnecessary or inappropriate. And then when you look at the animal prescribing, is in a similar way. Small amounts for treatment, large amounts for prophylaxis and as growth promoters. And again, highly questionable in terms of use. Look at the biggest continent country in the world. And if you look at this astonishing data that it consumes, an average Chinese person consumes 138 grams of antibiotics a year, 10 times more than a person in the United States. The World Health Organization recommends that the inpatient rate of prescribing should be around 30%. When you look at Chinese hospitals, 80% of all patients admitted to Chinese hospitals will get an antibiotic. And 97% of all surgical patients in China are given an antibiotic. So the global problem of use of antibiotics and the burden is absolutely massive. If you look at data over 10 years, this is one of the finest pieces of epidemiological consumption work done. And they've taken the 5 largest countries in the world: Brazil, Russia, China, India, and South Africa. Overall, the world saw a 36% increase, but these 5 countries accounted for the 76% of this 36% increase. But even more alarming was the increased consumption of carbapenems, 45% increase over a 10-year period, and a 13% increase in polymyxins, colistin, polymyxin, etc. Look at where we are in terms of the misuse of these antibiotics. If you look across the European continent, the red zones are the very high prescribers, and we call them the southern Mediterranean countries or Club Med countries because we all go to seek the sun and our vacation over there. But if you look at the amount of prescribing, very high. Look at outpatient prescribing across the world. There is quite a lot of distribution of amount, and this shows that across the European continent. But the biggest challenge remains non-prescribed medication. And I refer you to particularly the only data is in Jordan. 40% of all antibiotics prescribed are not prescribed by a pharmacist or a clinician. And you can buy them in the streets and in shops. And you can do that in many parts of the world. And again, it's showing how do you regulate, how do you control that particular problem. You may say this is not a problem in the Gulf or in the Middle East. And this is data showing you data from pharmacies in the Middle East. And it's showing you that the percentage of pharmacies willing to sell antibiotics without a prescription, depending on the demand for the patients. And what it's showing you, this is just one example, across the Gulf and across the Middle East, antibiotics are very commonly overused and often for prophylaxis, because you may have a cold, but you want to stop yourself from getting a bacterial infection. So when we come to the hospital setting, we have a huge challenge. And all of us work in the hospital setting. This is my favorite doctor who works in my hospital, and it's House. Do you all know House? Yes, some of you do, all right? So this is what we have to deal with when it comes to the hospital setting, is that who is going to watch, wait, and not prescribe? That's obviously an infectious disease physician, all right? I'm just joking, but so the majority, and you'll recognize all the doctors. So the person who will immediately say, fever, I will go and prescribe Cefepime, and then somebody will say, I will give meropenem with vancomycin. That's usually called a surgeon. So whenever there is a fever and an unwellness, that's what they will do. And then finally, as you go around the range of clinicians trying to make that decision, you will get the hematologist. Ceftazidime, clindamycin, gentamicin, caspofungin, and maybe some acyclovir, and see what happens. So that is the challenge that we have. How do you inform, help, and change that decision-making process to help them prescribe better? Well, if you look at data published in Social Sciences Medicine, it tells you about the brain thinking of how you may change that behavior around lack of knowledge. That's what we're here to help. But lack of trust or delay in the laboratory result. How can you get that help the clinician prescribe? The desire to meet the patient's demand, the fear of failure, and increasingly we're in an environment in which people are worried and scared about getting it wrong. So how do you deal with that? And you'll hear in the workshops about how we manage some of those anxieties from a clinician perspective. So when you look at the drivers of poor prescribing and resistance, the burden, the pathogen is one, the physician knowledge, the patterns of prescribing and diagnostics, you'll hear more, the patient's education and beliefs, the population in terms of transmission of infection, how we deal with pharmaceutical industry with regarding to the promotion and marketing of antibiotics, and how do we bring about regulation, and that's the politics. So all of these things are actually very important when you come to think about stewardship and resistance. And the three ways of fighting resistance is the use of new drugs, and new drugs in the pipeline are relatively small. The importance of infection control and hygiene, that's the second. And what stewardship is about is improving the use of currently existing resource as well as new antibiotics whenever they come. Use them only when they're needed, correct dose, correct duration, and correct intervals. And it is a fantastic paper that I'd ask you to look at in Science. It talks about, should we just go and try to invest in getting new drugs? Or should we actually spend what we're doing today around preserving what we have better? The balance between innovation and conservation. And he made a fantastic guesstimate of if you delayed resistance A 1-year delay in the need to invest, it takes around $1 billion to invest in a new antibiotic. It is worth roughly $60 million. So what it's saying is that by slowing down resistance is a very cost-effective strategy as opposed to purely relying on investing increasingly large sums of money on new drugs. So I think this is a fantastic piece of paper, begin to say to them, what we're doing here today and what we will do over the next decade is worthwhile from an economic perspective as well as a clinical perspective. So, what are these concepts, very briefly? This is an easy way of remembering the mechanics of antimicrobial stewardship. It's optimal selection of dosage, duration of treatment. So it's how to use the drug, the dose of the drug, the duration of the drug, and the de-escalation. So you can go away as a very clear message, and you will see that theme in many of the workshops and many of the sessions. But what you want to achieve is, to me, the most crucial. So when you go and talk to your surgeon or to your intensivist, don't say that this stewardship program is there to reduce cost. The stewardship program is to improve the outcome of the patient that you are looking after. That is how you convince clinicians. You say to him that you will make the environment of that patient safer, patient safety, and you will reduce in the fullness of time resistance, toxicity, and collateral ecological damage. The cost bit is when you have a conversation with the administrators and the pharmacists, because that is what they are managing. So you have to use the arguments around the different goals to different people. And you have to show to them, and you have to tell that surgeon, you have to tell that intensive care unit that you are not going to do that patient harm. And this is data from Singapore showing that stewardship will not increase mortality. Because when we put a stewardship program in my hospital, they said to me, Dilip, you're going to kill patients by not allowing me to use Piptazo on all our patients, or you're going to cause harm. And you increasingly have to convince them that stewardship is not all about restriction and causing harm, it's actually optimizing the way we conduct our affairs. And Tariq didn't show this slide to you yesterday when he talked about the intensive care unit. But if you do stewardship in an ICU, you do not increase the mortality or the complications of these patients in an intensive care unit. So stewardship is safe as well as effective. If you will see data of the effectiveness, the evidence-based, this is a Cochrane review, and what it shows is stewardship will improve clinical outcomes, but will not cause harm. It will reduce surgical site infections. It will stabilize and sometimes reduce resistance. It will improve CDI rates, and depending on which healthcare setting, it will reduce cost. But the data is too much from the West. I urge all of you to share your data in the literature, because then we will learn about the whole global landscape of prescribing and stewardship. So I encourage all of you who put programs into place, do it in a scientific manner. And we heard the Prime Minister talking about the need for research. And I think this is a fantastic opportunity that your Prime Minister here talks about to lead the way in terms of data. I'm going to finish very shortly. So what are the interventions? There are many, and you'll hear about them later on in my presentation, about formulary restriction, pre-authorization, audit, and feedback. This is a more recent systematic review, just published in 2014, that tells you how things are effective, what works and what doesn't work. Mark Gilchrist will talk about that later, and I will in my talk later on this afternoon. These are the front-end and the back-end stewardship strategies. But in the sense of, if you wanted to start a stewardship program, there are 5 things you need to do. You need leadership. You need somebody to take responsibility. You need expertise, pharmacists, microbiologists, infectious diseases. You need to start doing one thing, two things. Don't do too much. Just start 2 or 3 things and then build on those. That's the action. You need to know how, whether you're evaluating what you do, the tracking bit, data. You need to report and feed back that data to the people that you're trying to influence, and all of these need to be supported by education. You need leadership, all right? This is what I do in my ward round every morning, but you need to provide that in your hospital. So you need to find somebody in your hospital who will take the responsibility for stewardship. This is data from Philips Global Survey that shows lack of people and funding and lack of information were the 2 biggest drivers or barriers to stewardship. You need an organizational structure. This is ours, but you need to apply that to how your hospital works. You need to work with infection prevention teams, safety teams, and management, and you need to put stewardship as an important part of that. You need to do things in a coordinated way. Do the easy things first. Human beings try to do the hard things. When we fail, do the easy things first. Measure them, and we'll hear a whole workshop on measurement. This is data from what physicians and pharmacists in the United States use. I don't like a lot of their measures, but here I put this paper up. These are simplistic process measures, outcome measures, and balancing measures. And you need to work your way what applies to you and design them for your own purpose. You need to think, what will I do with this data? Do I use this data to drive improvement, or do I use this data to actually be accountable and responsible? So you need to think about how you're going to use that data. You need to think about how you feed back that data. This is Cochrane Review. So if I'm interacting with you, sir, if I don't give you the data I have presented about your practice and explain to you, educate you, and support you, there is no value to that data. So it's very important, the concept of feedback and action. And if you do that, your data becomes much more helpful. You need to educate better. This is a terrible way of long-term education. It has to be relevant, it has to be team-based, and it has to be interactive. That is the most powerful way of educating someone. We're going to produce a massive online interactive educational material. It is starting in October, and I would urge all of you who are interested to take part. It's free, it requires 6 weeks of your time, and it will be a very interactive tool around antimicrobial stewardship. So that's an opportunity for you. You will learn about how you change behavior, social, behavioral, organizational, implementation science, and change model as part of this course. So again, attend these workshops to be able to cover many of those. And remember, we all go through this journey. Yes, I'm done. We all go through this journey from the top to the bottom. I go through anxiety. This is a happiness phase of mine, but that will soon change to fear, depression, because you try to change human beings' behavior. But ultimately, the slope will improve and we will achieve what we wish to achieve. So remember those 5 questions. The first one is a 36% change in consumption. The misuse of antibiotics in the Gulf is huge. It is true that we need to achieve those 4 goals that I talked about. This method of education is not the most effective way. It needs to be interactive and team-based. And I think the 5 structures around leadership, accountability, education, and so on are very important in what you need to achieve when it comes to stewardship. So I'll stop at that, and thank you very much for your attention. Are we going to take questions now, or we'll leave them at the end? Okay, so I'd like to now thank you for that and introduce the next speaker.